Well, good morning, everyone. Um, my name's Andrew Johnson. I work in CAMH education, where I'm the manager of patient and family education. So I'm just trying to get organized here just a little bit. There we go. Please forgive me. Um, I need all my notes. So we're here in the opioid use in primary care conference to hear about opioid agonist prescribing in Canada, a case of regionalized knowledge sharing. It is my distinct pleasure to welcome Kelia Chu. Kelia is a postdoc fellow at the Bridgepoint Collaboratory for Research and Innovation, Lunenfeld Tannenbaum Research Institute in the Sinai Health System. Say that a few times very quickly. More importantly, Kelly's work involves conducting an international comparative policy analysis on opioid use disorder treatment in primary care settings, which aims to explore how different health system, cultural, and political factors may influence models of care. She is a registered pharmacist in Australia and has practiced in community pharmacy and has previous research experience in examining policy processes and the role of evidence in policy making. Welcome, Kelia. Please take it away.
Thank you, Andrew, for that introduction, and thank you for having me here today. Um, so the title of my talk is Opioid Agonist Therapy Prescribing in Canada, a case of regionalized policy. And there's a question mark at the end because I'm hoping that this is something that, we can all explore together. There's still a lot of unanswered questions, and I'm happy to take you through this project that me and my team have been working on. So just to say up front that this particular study has received support from a CIHR grant, and I myself am funded on a grant from the Health Canada Substance Use and Addictions Program, and I have no conflicts of interest to disclose. I'd also like to thank my fellow team members, so Chloe Campbell, who has spent a lot of her time on this project as well, and Dr. Abhimanyu Sood. Okay, so to begin with, we might start with looking at some context around opioid-related harms, and I'm sure a lot of you are probably familiar with this, but this is going to be helpful in terms of understanding the current context in this country. So obviously, opioid-related harms continue to escalate in Canada. Between 2016 and 2022, there was almost a doubling in the number of people dying due to opioid toxicity. And what we're seeing is that these harms are not evenly distributed across the country. So, for example, specific regions in British Columbia have drug-related mortality rates of 42.9 per 100,000 in 2022. In Alberta, opioid-related deaths were 32.4 per 100,000 in 2022 again, so that's nearly twice the national mean. And these trends in the Western provinces have been primarily driven by the contamination of the drug supply. On the other hand, we see Eastern provinces have also had significant and growing opioid-related harms, but overall rates are substantially lower. So in Nova Scotia, as of 2021, prescription opioid mortality rates were more than triple those of non-prescription opioids, so 3 versus 0.9. And then trends in Eastern Atlantic provinces are less likely to be affected by non-prescription opioids and fentanyl contamination. And obviously, I think one of the complexities that we have in Canada is this federation, and so we are seeing differences across that, but then even differences in terms of like how data is reported as well, which can make it a little bit hard to get the big picture overall. So OAT, as I'm sure you're all aware, is a key response to opioid-related harms, but there are still a lot of challenges to access structural challenges due to a number of intersecting elements, so such as stigma related to drug use, and this can be from the public, from the community, from health professionals, from health services and institutions as well, insufficient prescriber training, other barriers such as stringent regulation of prescribing, which is what the focus of my talk really is on today. And all of this has made OAT one of the most highly regulated pharmaceuticals, particularly if you compare that to opioids for analgesia. So until recently, providers had to get a federal Section 56 exemption from the Controlled Drugs and Substances Act to prescribe, sell, provide, or administer methadone. But in addition to needing to comply with this federal regulation, healthcare providers also needed to comply with distinct provincial or territorial prescribing regulations around education, training, monitoring. It was under the oversight of the provincial regulatory colleges for medicine, the Physicians and Surgeons College, nursing, and pharmacy. And if you contrast this with prescribing opioid analgesics for managing chronic pain, they haven't been subject to the same complex regulations. So what resulted then was this complex multi-level regulatory landscape to prescribe OAT, which likely acted as a deterrent for health professionals to be engaged in care. So after consultation in May 2018, to reduce this complexity and address the increasing harms, Health Canada removed this requirement to obtain the Section 56 exemption for methadone. So as Canada is a federation and quite decentralized when it comes to health policy decisions and governance, we get a lot of variation between provinces and territories. So given the multi-level federalist nature of methadone regulation, we use the removal of the methadone exemption as an opportunity to examine regulatory policy responses to OAT prescribing. So we did this before and after the exemption removal within a province, as well as looking at between provinces as well. In addition to the differing regulations across jurisdictions, the diverse epidemiology of opioid-related harms, as we covered a couple of slides ago, means that these comparisons are important to understand policy responses and trajectories and opportunities for cross-jurisdictional learning. So we wanted to document and then compare and analyze these OAT policies and changes within each jurisdiction's particular health system context. So how did we do this? So we did a two-stage comparative policy analysis of provincial and territorial OAT prescribing regulations using documentary data sources. So firstly, what do we mean by policy analysis? So this generally refers to analysis of policy or analysis for policy. So we did an analysis of policy, which is usually retrospective, it's exploratory, we examine the decisions and again hope that there's opportunity for learning in other contexts. And in this case, potentially learning between contexts as well. And so in the comparative policy analysis field, we want to understand the relationship between policies, the contextual factors that shape it, and the effects of it as well. And so we can see how context can lead to similar or diverging policy agendas. And there are a couple of reasons why it might be useful. So firstly, learning about similarities and differences, learning why policies exist as they do and how they work in certain contexts, and then learning about the effects of policies. So for this particular study, it is fairly exploratory. We wanted to examine the similarities and differences. And then later on, when we move to the more discussion part, we also potentially want to examine why these prescribing regulations exist as they do. So we looked at the changes in the content of policies regulating methadone specifically for OAT before and after the May 2018 exemption removal. And then we looked more closely at the actual college, the provincial guidance documents to see if there were any cross-referencing of content And again, that's just to identify if there are any cross-provincial or national relationships. So again, that's kind of our hypothesis that maybe there might be something regionalized. So we drew from publicly available policies, guidelines, reports, education and training materials relevant to provincial and territorial methadone prescription requirements for OAT. As you can see here, I've just like screenshotted a couple of the college standards. And we found documents for all provinces and territories except the Northwest Territories and Nunavut. To get these documents, we did an online search in 2 stages. So we went to each regulatory college site to get the official standards and guidelines for OAT, any other relevant documents such as media releases as well. So we noticed that even if something was specifically about prescribing, often let's say the pharmacy college would write a standard about it or provide information for it. And then we did a general online search for the province and territory and methadone. We included English and French documents describing these prescribing requirements, and then we excluded documents referencing methadone for analgesia. We chose to only focus on medical regulations rather than pharmacy regulations, as we guessed that this would be most directly impacted by the exemption removal in terms of actual number of prescribers. We also noticed that there was significant variability around nurse practitioner prescribing rights. We couldn't actually determine, clear pre or post exemption removal patterns. So some provinces had nurse prescribing OAT really early on. So it wasn't a case of the removal of the federal exemption that broadened the methadone prescribing workforce. So for each jurisdiction, we constructed a timeline documenting all changes relevant to methadone prescribing. So we set a rough time frame of 2014 onwards, going back a couple of years prior to 2018. And then we had these reviewed by clinicians and policymakers with OAT expertise from each province to make sure that it was accurate and relevant. We couldn't find expert review for the Yukon. From these documents and our timelines as well, we inductively identified 5 broad categories of requirements. So these were not predetermined. We looked at all the documents and grouped together the different types of requirements that we saw, although this generally does align with what we know about OAT prescribing regulations. And then requirements in each category were coded as either mandatory or recommended. So how did we define each of these 5 categories? So education and training. So this obviously, any program introduced to increase knowledge or aptitude, very broad category, but also we noted that this is specifically to do with initial prescribing permission. So say if you're a new prescriber wanting to get into OAT, what requirements around education were needed. And often these are tools such as like webinars or accredited programs. Our second category was mentorship, so fairly straightforward, shadowing, residency, preceptor-based courses, and particularly as well, having that ongoing relationship with a mentor. So being able to find someone who is already working in this space to be able to follow them for a varying amount of time. Regular license renewal and CME, so to qualify for reapplication to the college for a continuing approval to prescribe methadone, and this varied by province in terms of how long the cycle lasts for, or whether it's rolling or a fixed date. So some provinces we found they had to renew every 3 years, some every 5 years, everyone renews on a fixed date regardless of when you get approved, which could potentially affect the number of prescribers as well. It could be an incentive or disincentive. And then there may be additional ongoing education requirements in the form of CME. Some provinces, or actually all provinces at the start, I think there was registration with the college as a requirement. So it's mandated, you apply, you get approval from the college to prescribe. And then finally, auditing your practice review as the 5th category, where a physician practices are subject to review either by peers or by their regulatory body. And this is explicitly stated to invoke ongoing auditing or practice review. So if it wasn't mentioned, we assumed there were no official requirements. So while we examined each province separately before and after the exemption removal, we also wanted to see if there were any cross-jurisdictional patterns. So we looked at each provincial college OAT prescribing standard for references to documents, policies, any training programs, and standards for other jurisdictions as well. Again, we inductively categorized these references and then mapped them in terms of what was referenced. So the content, education, guidelines, practice standards, and the strength of referencing. So whether it was an alternative, a recommendation, a requirement, or wholesale adoption of another standard. Okay, so what did we find? So this table is just a broad overview of each jurisdiction's prescribing requirements before and after the exemption removal. So we'll look into a couple of patterns that we found a bit more in detail. So prior to the removal of the federal Section 56 exemption, all provinces and territories required prescribers to undergo initial education and training related to methadone prescribing, as well as registration with the college. So you can see them highlighted there. We noticed that all provinces except for Quebec and PEI also required mentorship or preceptorship, and all provinces except Quebec required a regular renewal or CME. Notably, several of the eastern provinces didn't have any auditing or practice review requirements even prior to the exemption removal. You can see there. And so you can already sort of see a couple of patterns emerging from this. In general, we saw that there were fewer high-level differences in the categories of requirements across jurisdictions before the removal of the exemption. But we did notice that Western provinces seem to demonstrate tighter education and preceptorship regulation compared to provinces in the East. So for example, looking at Alberta and Saskatchewan to initiate treatment, there were things such as like you had to complete the methadone maintenance treatment course, gain experience in an OAT setting, undergo an interview with a registrar of the CPSA or the Saskatchewan equivalent as well, preceptorship until competence was determined, maintaining CME and training requirements, and maintaining association with other providers as well. And so in contrast though, and again, this is still pre the removal of the exemption, in contrast, the eastern provinces, so such as Newfoundland and Labrador, New Brunswick, Nova Scotia, Ontario, the requirements were generally an online course, an 8-hour to 2-day preceptorship, and additional training every 3 to 5 years. Quebec, we found, had the fewest requirements in the pre-exemption removal period. So it was just a 1-day professional development course and naming a mentor willing to support if needed. Now turning to looking at the post-removal of exemption. So after its removal, some provinces further relaxed prescribing requirements. So you can see I've highlighted there, Ontario, New Brunswick, Newfoundland, Nova Scotia, PEI, removed all or the majority of their pre-exemption requirements. And so in BC, Yukon, Alberta, Saskatchewan, Manitoba, there was little to no change in requirements following removal of the exemption. You can see with all the dots kind of filled in on the table. Obviously, all provinces without mandatory education or training would still strongly recommend ongoing training and education to providers, but we noted that it wasn't mandatory. We also saw that BC had unique requirements where new prescribers after the exemption removal had to complete education and preceptorship and report to the college, while those prescribers who previously held an exemption didn't have these requirements and could continue to prescribe without specific additional requirements. I mean, this is important because like as regulations for new prescribers are particularly important to consider as barriers. Like if we were thinking of this particular policy and the removal of it as something to facilitate increased prescribing, the fact that these still exist for new prescribers, we considered, as a barrier, as tighter regulations, so we included them in the table as well. Turning now to cross-jurisdictional referencing. So this is our visualization of the cross-referencing happening in the practice standards. So again, we have our content referenced in different colors, so education and training in blue, clinical guidelines in yellow, and the actual college standard in the pink kind of color. So that's like the whole provincial college standard. And then we have our strength of referencing, so whether another jurisdiction's content is suggested as an alternative, a recommendation, a requirement, or adoption, which, as you can see, only refers to the adoption of the whole standard. In terms of the direction of content moving, so A to B reflects A referencing content from B. We didn't want it to go the other way around because we didn't want to imply that a particular province was, I suppose, like enforcing that content. We also noted that if there were any differences before and after the exemption removal as well. So as you can see, BC and Ontario seem to be the two major nodes from which other provinces draw references as, leaders in kind of this space. So 7 references to BC documents and 9 to Ontario documents, we noted. More specifically, these are references to the major education and guideline providers. So obviously BCCSU and CAMH, highly referenced, that makes sense. Geographically, we sort of noted as well that BC acts as a kind of reference node for Western provinces and territories, and Ontario for Eastern and some Western provinces as well. We identified college standards from 2 provinces, so Saskatchewan and New Brunswick, that explicitly mentioned that they had adopted content from another province's standards, which would presumably include other requirements as well, such as preceptorship, registration, and auditing. So we noted at the front of the Saskatchewan document that they said that they drew from the Alberta document. For New Brunswick, their instructions to providers were, if you're after the French standard, go see the Quebec standard. If you're after English, we draw from Nova Scotia. Again, in both cases, these adoptions occurred within geographically regionalized, kind of the west and eastern side of the country. And in terms of effects after the federal exemption removal, it had minimal impact on this cross-jurisdictional referencing. So we identified a change in Newfoundland and Labrador and Nova Scotia's standards. So prior to the exemption removal, they required physicians to undertake training from CAMH, and this was downgraded to a recommendation. So that's in parallel with what we see with the exemption removal in the previous table. So this is still fairly exploratory. It's descriptive. We wanted to identify what was happening, but then we can kind of think about what this means. So again, we found a couple of patterns relevant to the larger context of opioid-related harms in Canada. We've got Western jurisdictions that had tighter prescribing regulations prior to the removal of the federal exemption, and a lot of these were maintained after as well. Eastern provinces had generally relatively loose regulatory requirements before the exemption, and they became looser still after the removal. We can sort of view Ontario potentially as the geographical center, as well as sitting in between these 2 regions with some restrictions removed and some maintained. In terms of the cross-jurisdictional referencing, we also saw patterns emerge in the referencing of these prescribing policies. So they were regionalized in that documents referencing resources of another province tended to be within the same geographic region, but they were also hierarchical in that they tended to reference resources from more populous provinces. So why might we see this happening? Firstly, the reasons aren't clear, and then the next steps for future research, but it's likely to be affected by geographical, political, professional factors. So obviously, the regulatory colleges of the more populous provinces have much larger dues-paying registrants. So, if you compare British Columbia with almost 12,000 registered physicians compared to, say, Saskatchewan, which has closer to 2,400, right? So they've got more resources, obviously, to develop and enact policies. And the same applies to health systems and health education institutions as well. But then we also have values orientation. So values specific to different jurisdictions likely also play an important role in drug policies, which of course include OAT regulation. So we have done previous work, including comparison of international jurisdictions, and have seen that places with more restrictive OAT policies tend to have more of an orientation towards abstinence or recovery-based approaches. And those with less restrictive OAT policies might be more oriented towards harm reduction. We're still trying to tease out that relationship, but definitely values and ideology play a role in this. So now we want to consider this kind of east-west regionalization of the policy response against the varying epidemiology of opioid-related harms in the country. And it raises some important questions. So there are higher rates of harms and specifically fentanyl use in the Western provinces, and increasing access and use of OAT, particularly methadone, is an essential policy response. Removing the federal exemption provided a window of opportunity to increase methadone prescribing and access. So previous efforts to decrease regulatory control of methadone have been associated with increases in treatment availability and use. But our hypothesis is that just removing the federal exemption isn't enough. There are a lot of other requirements that can act as barriers to providers choosing to start prescribing methadone. So then it might be expected that Western provinces, would have elected to relax methadone regulations, but we see the opposite. And so this is where it gets a bit speculative, and we can have this kind of discussion. Maybe it's like a chicken and egg sort of situation. So it raises the possibility that restrictive policies around treatment, around methadone, might be potentially contributors to higher rates of harm as well. So just in general, poorer access to care, and then the use of the contaminated drug supply. The Western provinces' lack of response to this particular opportunity that the federal exemption removal presented, it could be indicative that they're locked into particular policy trajectories of restrictive methadone prescribing, which could then be reinforced by the regionalization of kind of cross-jurisdictional referencing and communication. And if we think more broadly around policymaking, this phenomenon of regionalized policy communication is seen in other areas as well, in established what we call horizontal intergovernmental relations. So vertical intergovernmental relations would be between federal and subnational governments. Horizontal would be between subnational governments. So we do have examples, in the broader policymaking sphere. So like the Council of Western Premiers, you've got Forum of Premiers from, the three territories, British Columbia, Alberta, Saskatchewan, Manitoba. On the other side, you have the Council of Atlantic Premiers. So there are established institutions like this. And these relationships can be evident in other macro level policy areas like trade and labor, where that geographic and regionalization kind of networks make sense, but whether or not, or whether or how they're present in health or social policy is still unclear, but worth exploring. So I guess this kind of speaks to like broader cross-jurisdictional policy learning as well. So, we've set up this opportunity of where we can look at the similarities and differences and see what can be learned in terms of general drug policy approaches, other harm reduction initiatives as well. We see a lot of pilot programs potentially cropping up. And the adoption of this into other jurisdictions is also interesting to see. And obviously, it's context dependent as well. We can also learn about different health system resources and resourcing. So things like different providers, different settings, what is required to kind of get these policies up off the ground. So that's kind of grounds for further learning, particularly when it comes to opioid use care in primary care. But then obviously when it comes to policy learning, there are a lot of different processes that we have to acknowledge as well. So again, like local political context, political will, different health systems run differently, have different priorities. So understanding that context is important when applying potentially different strategies from other jurisdictions. Who are the institutions and who are the policy actors involved? Who do we have to listen to? Who can we work with on the ground that already has a foot in the door in this space? As well as I've put here national coordination. This is always interesting when it comes to federations. Would it help for cross-jurisdictional learning if there was a national body to kind of coordinate everything? So even speaking from my home country of Australia, I think this is always something that comes up, and it's a really hard thing to manage as well. But I've put it in question marks because you never know, there could be a potential opportunity there for facilitation. So what could be done next? So more diverse policy knowledge networks as well across the country should be developed. And this can facilitate a corresponding greater diversity and appropriateness of policy responses. And perhaps the use of intermediaries could also facilitate this. So again, we saw that Ontario seemed to sort of act as a central intermediate province with a balance of restriction and relaxation, and cross-jurisdictional referencing also sort of demonstrated its influence across both sides of the country. Other institutions are the more national reach and connectivity. So, like for example, the Federation of Medical Regulatory Authorities of Canada, so the groups of the regulatory colleges, the Canadian Research Initiative on Substance Misuse, so CRISM, again, national bodies that might have that kind of bird's eye view if we were to facilitate these kind of broader networks. And I guess our work kind of further shows the need to recognize the variation actually across the country in terms of epidemiology and policy responses. So a lot of the focus now has shifted to Western provinces, obviously with a focus of synthetic opioids and the unregulated toxic drug supply. And we need to maintain that focus and, have the responses to address that. But other provinces as well also face their own unique challenges around opioid-related harms. And the need for policy responses specific to their jurisdiction. So it's having that policy learning, but tailoring it for that context specific purpose. So just to conclude, I guess, so we looked at the various policy responses after the exemption removal. We found that there was greater restriction and they seemed to be in the West compared to the East. The referencing was regionalized and hierarchical. Again, in future work, we want to explore mechanisms of policy patterns as well. So thank you for listening. You can reach me at that email address, and also feel free to check out our team's work as well at subjectmatter.ca. So happy to take any questions.
Yeah, I hope, thank you so much. I hope that people do drop questions, comments, impressions into the chat. It would be great to see how all of that landed. Kelly, thank you so much. One of the early comments in here came from Laura Nixon. And Laura noted that Alberta's recent numbers are embargoed due to the provincial election. And that's, when you were talking about the number of overdoses per, I believe, 100,000. And, you were very polite around the kind of like politicization of this space, but we all know that this is a very contested space, and that evidence is political in this space. I'm wondering if you can, reflect on that. That is, are we comparing apples to apples all the way across the country? And if not, is that a scientific? Is there a scientific reason for that, or is there a political reason for that?
Yeah, 100%. So even in the table that I showed, you could see that some of the harms-related data was in reference to opioids or in reference to illicit substances, or as Lara's pointed out, those numbers have been embargoed. So we're actually not quite sure. I think a lot of the data sharing and the consistency of data reporting is missing, which obviously if you don't have good data, how do you actually figure out what to do? So definitely, I think that's an area in which, it's hard to reckon with, but you kind of work with what you have. When it comes to the politicization of evidence, so this is interesting because I think what a lot of times we consider, advocates consider as evidence might be different to what researchers consider as evidence, different to what clinicians consider, and obviously what politicians consider as well. And so I think there is definitely that politicization in terms of, in politics, right? Like you string together a story, you look at what evidence makes sense to you ideologically, and you kind of go with that. So there is obviously that happening. I think this is where it's really helpful to kind of, I suppose, know what policymakers have in mind. What are their ideational priorities? And kind of like frame the story around that. So often we see in terms of researchers, and I say this, as a researcher, is that we come up with our own results and we think that that's it. That's the end of the story, without actually knowing that, hang on, that's not really relevant to other people. And so I think there is often that need to kind of understand that there are political motivations, and while you have your research, you want to be able to kind of make that bridge over as well.
Great. Laura chimed in with another comment, which is would be really interested to learn what structures are needed and possible to remove the policy and legislative powers from provincial parties. I'm here. I can only imagine what is being referred to as not just provincial powers, parties in general, but around methadone, buprenorphine, OAT provision. And I would also be really interested, as you comment on this, for you to put on your pharmacist hat and think about maybe some of the pluses and minuses of that, especially around the provision of methadone, because I think a lot of people will know that when we started to think about education around the provision of methadone, it was as a response to coroner's inquests because so many people were dying of methadone overdoses because they weren't being titrated properly, especially initiated properly in the early days.
Yeah, so definitely think that education is a piece to that. There is a role for that, but I think often when it comes to bigger health and social policy, there are often so many other structures that affect it. Like I can, like you said, speaking with my pharmacist hat on, and again, I practiced in Australia, so not here, but I can imagine that the realities are sort of similar in that there is still so much stigma and discrimination coming from the health professionals themselves. So you can give them an education course, but there are still a lot of other motivating factors for them to decide whether or not to provide methadone at their pharmacy as a dosing point. And I think it's figuring out those kind of structures and facilitators as well. On a kind of surface level, it could be, funding, right? Like, how do we remunerate providers properly so that they want to do this? But again, I suspect that, more deeply, it's actually how do we, what is the view, right, of opioid use care from health professionals? And yeah, I think that's still something that we have to figure out.
Lee's made a comment here that the care support services for substance use is so fragmented. We need a streamlined system. And I hope that you'll reflect on also the bullet point that stuck, one of the bullet points that stuck out to me, which was, basically accounting for local realities. And how do we balance these things? Because I hear, Lee, it would be great to have a national standard, national approaches, nationally accepted data sets, everyone kind of working in the same playing field. But the reality is that, you know, rural Manitoba is very different than downtown Vancouver.
Yeah, and this is a really interesting question about fragmentation and a streamlined system. So I think even without going to the level of thinking about a national streamlined system, how do we even better facilitate care at like the local level, right? So this has kind of come up a little bit where it comes to the integration of care. So say, for example, you go to your primary care physician and you need a referral to someone like an endocrinologist or a cardiologist or something. That pathway is there, should be there. The primary care physician kind of knows where to go with it. And it comes to this fragmentation when we have people with substance use disorders or, needing that kind of care where there's, primary care doesn't know where to direct you, right? So you've already kind of got that split in terms of one system and another. And I think even kind of addressing that, let alone at a national level, addressing that is probably really important. And how do we better integrate and collaborate between those sectors? So that's a really interesting point that Lee raised in the chat. And then I guess in terms of the local context, so obviously an area that is more rural, more remote is going to have different needs to an area that is more, metropolitan, where there are more resources. I think this is where you can also utilize different workforces as well. So, in a rural area, probably you can have more care delivered by nurse practitioners, and that's going to be different to what you have in, say, a city. And perhaps maybe a national approach could be considering on like the baseline principles, right? Like we set a kind of standards, we set principles, and then you can tailor it for your specific context. So that might be what we get closer to in terms of like a national streamlined approach.
Is it not also that in different jurisdictions the actual drug supply? We all know that the drug supply has been adulterated all the way across the country, but in different ways with different kinds of adulterants, fentanyl, benzodiazepines, etc. And would that not be part of what people need to be responsive to at a local level?
Yeah, exactly. Yeah. So, having that flexibility to know, okay, what is actually causing the harm in my community and what can we do about it, versus just, having like a, blank response across the board. But I think, even across the board, we could probably, do a lot more when it comes to actually making it easier for providers to do their thing.
Jordana has asked a question. In your perspective, how might the mentorship component of prescribers' education and training influence the reinforcement and sustainment of biased, discriminatory, stigmatizing prescribing practices? It's a bit of a mouthful.
Yeah, thanks for the question. So I've got this correctly. It's focusing on the mentorship component and how does that further reinforce kind of the current stigmatizing prescribing practices. Yeah. I think it's interesting when it comes to the mentorship thing, right? Because it requires you to have that relationship with another prescriber. It requires you to do a certain like shadowing. And so it's kind of almost baked into the structure of the system where it's like like, how do we perceive? It's almost like prescribers, you know, you need to do all these extra steps. We can't trust you. We have to oversight you. And then I feel like that also sort of sets substance use care apart as well, right? Like, you need to jump through all these extra hoops in order to give this care, even though you don't need to do that for other conditions, for other chronic conditions, right? Like, and exactly right. Like, you've got established addiction medicine specialists potentially who have their way of thinking, and if you know you need them to kind of like we learn from people, and we learn from, you know, how they view things as well. So definitely that kind of perpetuates it. And I think, again, it sort of separates out this idea that like substance use care is just kind of separate from everything else you've got going on, rather than looking at it holistically. And, you know, I think there are a lot of other structures in place that are contributing to that kind of segregation, as well.
You know, one of the earlier comments here was basically, you know, that there needs to be more focus on substance use in medical school. And, you know, I wonder, you know, if anyone in your experience has experimented with not having, well, maybe not an either or, but having people with lived and living experience in the mentorship, as the mentor, as a way to start to bring the education level up in a very tangible kind of way, and B, really address stigma.
Yes, definitely agree. Yeah. And I mean, I'm not a med student. I've never gone to medical school, but I can imagine that kind of this, how it's taught probably needs to be completely redone and looked over. So, yeah.
I think we're starting to come to the end here, but maybe education and training in medical school and pharmacy school would be more generalizable rather than those in practice with ingrained stigma concerns. I'm not 100% how maybe this is commenting on you know, that idea of mentorship again.
Yeah, and I guess I will say again, can't speak for medical school, but in terms of pharmacy school where I
Hmm.
was trained, there was nowhere near enough discussion about substance use, or even the broader kind of social and structural issues and things that affect substance use, right? Like, I think we're only kind of starting to move. You know, we've moved away from thinking about it as a legal issue towards a health issue, but then I think even within clinical schools, the focus on having it as a health issue disregards thinking about other social factors that include it. And I think we probably also need to include that more into clinical curricula as well.
Okay. Just going back to the chat, see if there's anything more coming in here. A lot of talk about community engaged learning, but I feel we're a long ways away from moving forward meaningfully on this to include people with lived experience in educational roles, but agree that that's the exact needed direction. So, you know, like, there's lots of challenges in this space, but it would be, you know, something that we should at least explore.
So I see that there's a question from Rachel as well, about incentives or ideas
Yeah.
to encourage more practitioners to become OAT prescribers. Yeah, I think that's the real question, right? I So kind of in my work, we have seen a couple of things come up in terms of suggestions. If we're specifically talking about primary care, I think there's a lot to be said about primary care reform in general, and how do we incentivize more chronic and complex care delivered through primary care. Some of that comes down to like funding and remuneration. How do we retain physicians in the first place? How do we encourage them to not just use a consultation as like a quick fix? And I think that's really hard because that's the way that the fee structures are set up, is that it doesn't really incentivize and prioritize care for chronic and complex conditions. So for probably funding on a broader policy level. And I guess like it's tricky because I think a lot of like the fact that it's a choice. I think someone was commenting to me in community pharmacies, you can choose whether or not to dispense something. You can choose whether or not to prescribe. And I think a lot of that does eventually come down to like stigma and discrimination, how we, view people who use drugs. So I think, and again, that kind of potentially goes back to like education, like baked into the, medical curriculum. But I think that's also where we can start to sow the seeds of having like growing up in OAT prescribing workforce.
Lee's made the comment that substance use is now becoming as common as dealing with hypertension and needs more attention in medical training and pharmacy training. But you also made the comment that, and maybe this is kind of within this kind of regulatory and expectation space. Should it be, I can't imagine walking into a pharmacy and not having antibiotics available. But definitely you need to know whether or not the pharmacy is going to prescribe OAT or not, or provide naloxone kits or not. Is there any space for just having that as a base level expectation of pharmacy practice in Canada?
I mean, I think as you mentioned, conceptually, it's a little bit weird if you think about it, right? Like you can go in for one thing and then just not have it at all for methadone or buprenorphine. I think this would, like, you'd have to really work with and try to figure out a way to engage like the community pharmacy sector. And again, probably, similar factors as you would with primary care physicians, obviously slightly different setting, but, similar things when it comes to like stigma and discrimination and, like really helping to facilitate pharmacists to be able to provide that service as well. And I think we need to go in that direction, but I think it's possibly slow going. So
do you think there'll be an opportunity, for instance, with the introduction of universal drug with funding, universal, as that being a lever, because it's notable that dentistry and pharmacy in Canada are basically privatized. And but as we move towards public provision of this, would this become an opportunity to drive some of these changes?
Yeah, I think so. I think it also, right, like it sends a signal as well that it's, it's something that we think is as important as the, other medications, right? Like we set a national standard of saying, yes, we cover this. It's on the public insurance. So I think like levers like that are probably also really helpful. Yeah. Had a point I was going to make, but I can't remember it now. So
if it's a good one, then we'll come back. Are there any further questions, comments, impressions that people would like to share? We've got a few more minutes left. I checked in with the conference folks, and they let me know that we can have a few more minutes here. Going to give folks just a breath to see if you can get your ideas moving forward here. some nice comments, or sorry, compliments. Yes, definitely a good session. You know,
That's right.
it's interesting as much as many of us work in these spaces based on our values and our desire to support people to live their best lives. How essentially regulatory and other kinds of, call it, bureaucratic
Mm,
aspects of our lives can complicate that, and they seem really quite benign on the face of them sometimes, but then themselves become barriers to accessing treatment, to being um, met with a welcome posture in pharmacies, etc.
yeah.
So I thank you for doing this work. I think it's really very interesting. Lee has made a comment here: federal versus provincial funding regulation. Uh, Funding regulations are a huge barrier and have unique geographical barriers. I have to confess that this is well out of my expertise. Do you have a comment here?
No, but I agree. Yeah, definitely the way things are funded, um, and where the money is coming from, on a macro level as well, like whether something is provincially funded or whether you have to wait for the federal government to step in. That's an extra step, having that tension between those levels of government. Um, and then yeah, like geographically as well, it's so diverse. Where did the funds go? How's that prioritized? I think that's always going to be, um, yeah, a barrier, and but also potentially somewhere where we can work in as well. So yeah.
Lee has kind of expanded on that, put it in a little bit more context by writing. I work with indigenous populations that are quite remote.
Mm, yeah.
Is in your estimation, I live in the Greater Toronto area. I work in Toronto. One of the things that we always need to check ourselves around as we're, say, providing education or publications, which is the kind of work that I do, is to always check that Toronto bias. That
Mm,
is to remind ourselves that we, as much as we gripe about how stretched resources are, etc., that we're just swimming in resources compared to other jurisdictions. Is this kind of bias, or put on the blinders, is this reflected in regulatory policy in your estimation? You were talking about like how a lot of people are looking to CAMH or to the BC Center for Excellence, as their kind of north stars. And is there a risk that we're going to, reflect on Lee's point, higher needs populations that are living in under resourced areas?
yeah. Um, yeah, this kind of does go back to the point where, firstly, that kind of referencing is regionalized, but it's also, I think I said the word hierarchical, right? Like we're looking up. Um, and so I think it's always interesting, like for the research that we're conducting, we're trying to also include, other provinces that aren't just Ontario and BC as well, because, like they've got different challenges. We want to see what they're doing. Maybe they're doing something even better. So there is that like, yeah, you're right. We do have to check ourselves and make sure that, hey, it's not just focused on, right, like the, Greater Toronto area or whatever. um, I think just inherently, when it comes to like geography is one thing, right? Like we put in place regulations and requirements that are, it's not great. It's inconvenient for someone living in, say, downtown Toronto, but it could be even worse, right, for someone who is living in a remote area. And I think even not necessarily recognizing that is a problem. And so, yeah, I think there is still definitely, room to improve there. And how can we include those other voices who aren't just living in? yeah, more populous centers. Yeah.
Well, that brings this session to a close. I really want to thank you for really bringing a stimulating presentation forward and really getting us thinking. You've got a lot of thank yous in the chat, so I think a lot of people were definitely engaged by this. So thanks so much. Take
Excellent.
care, all.
Thank
Hope
you
you
all.
enjoy the rest of the conference.